Real briefly, I wanted to touch on hydroxyapatite. I think the long and short of it is that in some centers this is considered necessary, in other centers it's not. And it's unclear if in most modern iterations if it is necessary. Although the results with these types of stems are excellent, the addition of hydroxyapatite in most cases does add to the cost of the implant. Next, I just wanted to touch on compaction broaching, which kind of like the direct anterior is kind of hot right now, as Karsten had said. And I think the two are kind of linked because a lot of surgeons who do the direct anterior like to use this type of stem. Primary fixation is in the metaphysis, although it does get some diaphyseal fixation as well. In general, these stems are made of titanium and fully coated with hydroxyapatite. It's a broach-only technique, so it's quick and relatively easily. Excellent results have been reported from most centers, and I think it is adaptable to just about any surgical approach. I think cons can be difficult to get these out. Again, these are fully coated with hydroxyapatite, and if these osseointegrate fully, they are just about as hard to get out as a AML. And can also be difficult, again, in patients with tight canals if you don't ream them distally, so something to watch out for. The final thing I'm going to touch on is short stems. Short stems, at least in North America, seem to have a moment, so to speak. With the FDA approval of hip resurfacing in the United States, I think people saw this as a conservative option. I think in situations like this where you have retained hardware or a funny deformity of the femur, knowing how to use these stems is a nice tool to have in your pocket. They do potentially preserve bone stock for the future. Not 100% sure how much easier they are to remove, but they should be. But there certainly are some cons. Again, I think that these do have a real risk of periprosthetic fracture. And the fixation becomes really critical with a shorter stem. So I don't think we know how short is too short, but certainly something like this can be very technique dependent. So I think the take-home point is we're lucky. There are lots of options out there that work very well. All have pros and cons. I think you need to pick your poison and really understand and stick with one surgical technique. I know there's some literature out there that shows that in particular low volume surgeons tend to switch around a lot and use lots of different kinds of implants, and in general I think that's going to be your worst results and your highest risk of complication. So pick one stem, pick one philosophy, get really good at it and use that all the time. Thank you.